My name is Alyssa Osmonson. I'm a PGY1 pharmacy resident from Princeton Baptist Medical Center in Birmingham, Alabama, and I will be presenting on guideline-directed medical therapy after heart failure exacerbation. My preceptors and I have nothing to disclose. The 2017 Focus Update to the 2013 Guidelines for the Management of Heart Failure with Reduced Ejection Fraction recommend the use of guideline-directed medical therapy consisting of a renin-angiotensin-aldosterone system inhibitor in conjunction with an evidence-based beta blocker for all patients to reduce both morbidity and mortality. RAS inhibitors include angiotensin-converting enzyme inhibitors, aldosterone receptor blockers, and the angiotensin receptor neprilysin inhibitor. Evidence-based beta blockers include bisoprolol, carvedilol, and metoprolol succinate. Heart failure is included as one of the 6 medical conditions measured by the CMS Hospital Readmissions Program. 30-day readmissions related to heart failure result in reduced payments to hospitals. Discharge prescribing patterns at Princeton Baptist Medical Center as they relate to heart failure with reduced ejection fraction are currently unknown. The purpose of this study was to identify if appropriate guideline-directed medical therapy was prescribed at discharge following an admission for a heart failure with reduced ejection fraction exacerbation. This was a single-center IRB-approved retrospective chart review performed at a community teaching hospital. Charts of patients that were admitted with a primary problem relating to heart failure from August 1, 2017 to July 31, 2019 were identified and reviewed. Statistical analysis included descriptive statistics and chi-square tests with a p-value of 0.05. Patients were included in the study if they were 18 years of age or greater and had echocardiogram documentation of an ejection fraction of less than or equal to 40%. Patients were excluded if they had a history of heart transplantation, an EF of greater than 40% or undocumented, death during admission, or pregnancy. The primary outcome assessed was the percentage of patients discharged on guideline-directed medical therapy. Secondary outcomes included percentage of patients discharged on a RAS inhibitor, percentage of patients discharged on an evidence-based beta blocker, reasons why guideline-directed medical therapy was not prescribed at discharge, readmission within 30 days, and readmission within 30 days related specifically to heart failure. A total of 451 patients were screened. 233 were excluded, the majority of which were due to having an ejection fraction of greater than 40% or undocumented, and a small number due to death during admission. 218 patients were included. The average patient included in this study was a 66-year-old male. The patient population was roughly split evenly among white and African American patients. Looking at the primary outcome of percentage of patients prescribed appropriate guideline-directed medical therapy, 125 patients, representing 57% of the patient population, were not prescribed the recommended combination of an evidence-based beta blocker and a RAS inhibitor. 93 patients, or 43%, were prescribed guideline-directed medical therapy. Looking next at the component parts of guideline-directed medical therapy independently, 59% of patients were prescribed a RAS inhibitor at discharge and 41% were not. Looking next at evidence-based beta blockers, 71% were prescribed either bisoprolol, carvedilol, or metoprolol succinate, and 29% were not. Taking a closer look at the 125 patients that did not receive guideline-directed medical therapy, 86 patients were not discharged on a RAS inhibitor, 62 patients did not receive an evidence-based beta blocker, and 27 patients were discharged without either a RAS inhibitor or evidence-based beta blocker. When analyzing the reasons why a RAS inhibitor was not prescribed at discharge, it was determined renal dysfunction was the primary limiting factor, followed by intolerance, allergy, and hyperkalemia. 13 patients were not placed on a RAS inhibitor due to some unknown or undocumented reason. When looking at reasons why an evidence-based beta blocker was not utilized, it was noticed that the use of an alternative beta blocker was the primary reason one was not prescribed. Of the 44 patients that received an alternative beta blocker, 33 received metoprolol tartrate. A small number of patients had an intolerance, received alternative therapy, or had a contraindication to beta blockers, and 5 were not placed on an evidence-based beta blocker for some unknown or undocumented reason. Continuing with our secondary outcomes and now focusing on readmissions, of the 93 patients that did receive guideline-directed medical therapy, 32 were readmitted within 30 days, and 20 of those readmissions were related to heart failure. Looking at the 125 patients that did not receive guideline-directed medical therapy, 54 were readmitted within 30 days, and 28 of those readmissions were related specifically to heart failure. Looking next at readmissions related to heart failure and comparing the two groups head-to-head, the percentage of patients readmitted relating directly to heart failure was 22% in each group, with an associated p-value of 0.875, not demonstrating statistical significance. Taking a closer look at those who did not receive guideline-directed medical therapy, of the 86 patients that were not prescribed a RAS inhibitor at discharge, 39 were readmitted within 30 days, and 21 of those readmissions were related to heart failure, representing 24% of this subgroup. Of the 62 patients that were not prescribed an evidence-based beta blocker at discharge, 25 were readmitted within 30 days, and 10 of those readmissions were related to heart failure, or 16%. Of the 27 patients that did not receive either a RAS inhibitor or evidence-based beta blocker, 12 were readmitted within 30 days, and 4 of those readmissions were related to heart failure, or 15%. No statistically significant difference was found between subgroups. There are several limitations to the study, first of which being a retrospective review with a single-center design and small sample size. We did not evaluate the use of other agents common to heart failure with reduced ejection fraction regimens. The study relied heavily on accurate documentation, and patients could have represented at outside hospitals or could have been initiated on guideline-directed medical therapy by a physician in the outpatient setting. In conclusion, discharge prescribing patterns as they relate to heart failure at Princeton Baptist Medical Center are largely not in accordance with current guideline recommendations. However, this did not lead to a statistically significant difference in the rate of readmissions due to heart failure based on the data from this study. The majority of patients that were not prescribed a RAS inhibitor at discharge had a valid documented reason to not receive one of these agents. However, with regards to evidence-based beta blockers, the majority of patients did not have a valid documented reason to not receive one of these agents. Although there is not a statistically significant difference in readmission rates based on the findings of this study, previous data has shown the benefits of the use of guideline-directed medical therapy, and there are several opportunities for improvement in this area at Princeton Baptist Medical Center, including a focus on heart failure regimen optimization for improved outcomes, and the possibility of an enhanced role of pharmacy medication review and intervention prior to discharge, including the potential for implementation of a heart failure with reduced ejection fraction specific transitions of care program. I would like to take the time to recognize my project advisors and our statistician for help in completing this study. This concludes my presentation.